Welcome to Psych Talk for primary care providers, where our esteemed faculty members will provide you with invaluable insights to seamlessly integrate into your daily practice. Today, we will have Dr. David Marcovitz talk about co-occurring psychiatric disorders and how to treat them best.
Hi, I'm Dave Marcovitz, and I'm an addiction psychiatrist at Vanderbilt University Medical Center in Nashville, Tennessee, where I direct our division of addiction psychiatry. I'm also very passionate about collaborative care with other specialties, especially primary care, and I'm delighted to be part of the TNT program. One of the topics that I wanted to share a few pearls about today is the topic of co-occurring psychiatric disorders. This is a topic that's very near and dear to my heart, and really one of the reasons I went into addiction psychiatry, because I noticed that when you treat patients for their substance use disorders and their co-occurring psychiatric disorders, they really value it. They get better faster. They feel understood in a different way. It's very meaningful. I'll give you an example. Early on in training, I met with a patient who had bipolar disorder and alcohol use disorder. And when he first came in, he was quite manic. But by treating his co-occurring bipolar disorder, he was really able to dig in deep on the work for his alcohol use disorder and get more accomplished in terms of his early recovery and also his family support. So I'll share a little bit about co-occurring disorders. It turns out that about half of patients with a substance use disorder have a co-occurring non-substance psychiatric disorder. So for today, I'm not talking about patients who have more than one substance use disorder, although those are also referred to as co-occurring disorders. The most common co-occurring disorders we see would be depression and anxiety. And the pearl for our TNT fellows and for others is that you need a period of about 30 days of abstinence in order to make a diagnosis of a mood or anxiety disorder, but you can also make the diagnosis based on the history. So some patients may tell you that they've had sober periods in the past when they've been depressed or anxious, or before they started using substances. Another important tip is that when you're asking patients about co-occurring depression, anxiety, bipolar disorder, you have to think about the specific DSM-5 criteria by asking screening questions to rule in or out the disorder. So, for example, if you're talking to a patient with an alcohol use disorder and you want to know if they've had episodes of major depression in the past, you would say to them, have you had a period when you were sober for at least 2 weeks where most of the day, every day, you felt down or depressed every day, or you couldn't enjoy anything most of the day, every day? And simply by asking that one screening question, you can rule in or out major depressive disorder very quickly. So in summary, co-occurring disorders are extremely common. 50% or more of patients with substance use disorders have them. And when we treat them, we see much better outcomes. In contrast, when we don't screen, diagnose, and treat them, patients are less likely to get better because of how difficult those symptoms make it to recover from substance use.